Hello, everybody. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Prrt Therapeutics. My name is Rain Bennett. I am your host every week, and I'm a filmmaker that's been working with CCF for 10 years. That's a decade of my life and career dedicated to the foundation and you fine folks. So I appreciate you being here. And this is I love this part of the work that I do with CCF. I've done a lot of videos, which you can see on their YouTube channel and under the videos tab here on the Facebook page, usually like short form documentaries, some event coverage from conferences long ago. But this program that we've done that really took off when the pandemic hit and forced us all to be home has just been so fulfilling. I love the community that is growing from it and seeing your comments every week. And so I'm just so appreciative. And I see everybody is starting to join and tell us where they're signing on from. We love to see that. We've already got Canada in the house and a lot of the Midwest, it seems like, Michigan. So do that. If you're a first timer to the show, let us know where you're signing on from. We'd love to see how far these programs reach. Inevitably, every Thursday, even though we're in Eastern time zone in the States, we have people from all over the world in places where they should probably be asleep, but they're here learning and helping us cultivate this community. And I, for one, love that. So before we get started, we always like to thank Prrt Therapeutics, our presenting sponsor, because without them, this show wouldn't be possible. And we also like to include this little disclaimer from them, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience at home, haven't been created or suggested by the sponsors of Lunch with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. All right, so again, I reiterate this every week because that last line is really the takeaway I want you to focus on. We're going to give you some good advice, general advice, answers to your question, help you along your journey, but by no means do we or our guest today know your specific case. Take that advice, take those answers back to your home team who does know your specific case, and make the best plan for you moving forward. As we all know that each case of this disease is unique, and therefore each path is as well. So today I'm excited to announce that our guest is Dr. Namrata Vijayvergia. Welcome back to, well, we did not this show, but we did another version of what would you call it? The prototype of Facebook Live show. How are you, Dr. Vijayvergia?
I am very well. How are you doing, Rain? Thank you so much for having me on the show.
Yeah, absolutely. It's good to see you again. I hope everything has been going well. For those that may not know you, tell us a little bit about yourself. And the way I like to ask it is the role that you fill in this neuroendocrine tumor community.
Yes, thank you. Well, I am very fortunate to be a part of the neuroendocrine community. That I can tell you for sure. No, it's really a part. I am a GI medical oncologist, so I treat all GI medical cancers. But I have a special research and clinical interest in neuroendocrine tumor management. And I can tell you, like colorectal versus neuroendocrine versus any other cancers that I see, the close-knit community of the net providers, the net patients, the groups, the patient support groups, it is beyond par. Like it's, I think, way above. Like everyone else is like taking I could say tips or ideas from us to develop that in other areas. And I just am so fortunate to be a part. But yes, I do GI medical oncology. I am a assistant professor and the assistant chief of GI medical oncology at Fox Chase Cancer Center. It's in Philadelphia. It's a comprehensive cancer center. And we see about 80 to 120 patients, new patients per year, and have a very a net specific dedicated multidisciplinary clinic where we see all our patients and provide very high quality care, try to provide the highest quality of care that we can for our patients here.
And that 80 to 120 that's of net patients?
Yeah, new net patients here.
Yeah, and what percentage of that what percentage are net patients of your total patients that you see?
So my practice is 70 to 75% neuroendocrine tumor patients.
Wow. Okay. That's amazing. And speaking of Fox Chase, I see we had where did that go? We had a little shout out from Karen. Karen from Fox Chase says, we are so fortunate to have Dr. VJ on our staff. Well, thanks for joining us, Karen. I appreciate you being here. So folks, listen, here's how the show is going to go. We are going to take your questions. Every week you send a lot of questions, which is what we're here for. Sometimes, most of the time, we don't get to all of them. So I really encourage you that if we don't get to your question, or if the answer we give you prompts a follow-up question and we don't get time to get to that, listen, send a message to CCF either here on their Facebook page. You can private message them. You can reach them. You can email them at their website, carcinoid.org. They will get you that information. Now, this video is going to live here, evergreen. After the show, it's going to be posted, so you can always access it. You can always come back to it starting Monday. It'll be on YouTube, so anybody that doesn't have Facebook can access it. But this is really the benefit is being here live in this virtual one-on-one session. So if you know anybody that would benefit from this interactive session, go ahead and tag them in the comments. Share the video to their news feed. Any way that you can let them know this is going on. We want to get as many people here as possible. Okay. And another thing that I like to ask of you all, I'll say it every week because you all are doing a really good job of it, and it really helps me. Okay. If you see a comment or a question in the sidebar that you also have, if you just below the comment, there's a reply button, there's a like button. You can like it, you can hover over that like button, and it gives you a whole host of emojis you can use. They all work the same way for me, and that effectively upvotes that comment or question, so I see there's a demand for it. So if I see 7 people have that question, well, that tells me, hey, Rain, this is an important question to get across, because as I already said, we get so many that we inevitably don't get to all of them. Now, I have an announcement today, a specific announcement for our guest. Dr. Vijayvergia will be one of the neuroendocrine tumor experts participating in an industry satellite program hosted by ITM AG, a leading radiopharmaceutical company, at the European Society of Medical Oncology, or ESMO, Congress 2021 tomorrow. Is that right?
It's actually at 4:30 a.m. U.S. time, so
fun.
I better get my sleep tonight.
And that is called A Global Perspective on the Management of Neuroendocrine Tumors, the Evolving Role of Targeted Radionuclide Diagnostics and Therapy. The symposium will feature key opinion leaders from around the world who will lead discussions addressing the changes within the treatment and diagnosis of neuroendocrine tumors. Dr. Vijayvergia's presentation will focus on the evolution of guidelines for the treatment of NETs. Can you tell me a little bit about that event and the impact that you hope that it has?
So I think the main idea behind that symposium, so this is a ESMO Congress, so it's like equivalent to the ASCO that we have in America. If a lot of you may have heard, it's the major oncology conference. So it's not specific. So there's a European Neuroendocrine Tumor Society, like ENETS, which is just neuroendocrine professionals. This is for oncology professionals at large. And so the goal of this conference is to educate oncology providers that probably don't see as much neuroendocrine tumors of how has the neuroendocrine field changed over time, and the new therapies that are coming up, and what are the unanswered questions that we need to answer, and what are the new guidelines. So my part in it was evolution of guidelines, was to update people of like all the new differences that have come and all the different guidelines that are available to help providers that probably don't, so if you ask me, I remember those guidelines, I'm part of those guidelines too, so it's easier for me. But if you go to a doctor who doesn't see these patients all the time, this is a good way, or our efforts to teach them about the various guidelines that are available for them to look up and follow, so that they can provide optimal care to our patients. So I think educating the oncology community at large, because we all know the NET frequency is increasing by the year, right? We know that over 40 years it's grown up by 7 times. So more and more people will encounter these patients, and we just need to do a better job at educating everyone, so a patient doesn't have to travel 500 miles to see an expert.
Yeah, absolutely. Absolutely. So folks, go ahead and start sending in your question. I have given you my asks for today. Let's try to get as many people here as possible. And don't forget to upvote those comments and questions if you also have them. And as I already mentioned as well, the video will live here. And if you don't get your question answered, go ahead and reach out to CCF, either privately here on the Facebook page or at their website. And one final announcement before we get started. Today and throughout the month of September, we're recognizing and appreciating amazing women physicians in the NET community. September is Women in Medicine Month, an annual program of the American Medical Association. And we'd like you to join us as we thank NET physicians for sharing their expertise, care, and compassion throughout the year. And we're thrilled that today, for the remainder of this month, we are featuring women NET physicians during Luncheon with the Experts. So we appreciate you being here, Dr. Vijayvergia.
Absolutely.
Let's start the show, folks. Okay, one thing, and also Dr. Vijayvergia wanted me to mention earlier that she goes by the name Nina. I am wired to be very professional in my role here as the host at Lunch with the Experts, so I said Dr. Namrata Vijayvergia. But just so you all know, I think her name may say Nina down there. That is what she goes by. So I will still be referring to her as Dr. Vijayvergia. So listen, Dr. Vijayvergia, or somebody called you Dr. Vijay in the comments. Is that common?
Mm-hmm. Yeah,
okay.
Most of my patients call me that.
Gotcha.
Dr. V, Dr. Vijay,
Dr. V,
whatever
works. So you'll learn through this program, and you've already alluded to this about the NET community, that our patients and our community members are very well educated in this disease. However, we get a lot of new people on the show every week, and it's important to me that we lay some foundation. So I may pause you as we go along and say, like, let's explain what that acronym means or something like that, just to lay some groundwork. But we've got a great first question from Rebecca, which essentially does that in the world of scans specifically. So Rebecca says, what is the difference in a CT scan, an MRI, gallium-68 PET scan? If the NET cancer doesn't show in the CT or MRI, then why do we do those scans? And I think that's a good opportunity too to just discuss the scans that are available.
Absolutely. So, diagnosing neuroendocrine tumor, as I just made that presentation of evolution of guidelines, has changed dramatically in the last 5 to 10 years. Previously, we would do something called an octreotide scan. That was an older version, still available, but it's very think of it as an archaic way to look for neuroendocrine tumors. Mm-hmm. And there are two major types of scans that you can do. One is called anatomic imaging, and the other one is called functional imaging. Okay. Anatomic imaging is just giving you a black and white picture of your organs, right? It's giving, you see some organs black, some white, some gray, and you can see some tumors in there, right? But if you see a tumor, you don't know if it's a neuroendocrine tumor, or is it a regular cancer, or is it something benign, right? It's not cancer, let's say. So you see tumors in that. Those are CTs and MRIs. CTs are extremely good for the lungs, for the abdominal cavity, for lymph nodes. MRIs are extremely sensitive and very good. They give the very good anatomic picture of the tumors in liver, extremely useful for the liver, because you can literally see the tumors, what they are in relation to the blood vessels, because all of these things are very important for us when we devise treatment for patients. Now, these are anatomic imaging. The other one is the functional imaging. Functional imaging is all the scans that we do which are specific to neuroendocrine tumors. So, we all know these neuroendocrine tumors are very special. They exhibit this special protein or a receptor on their surface called the somatostatin receptor. And what we found is a drug that goes and attaches like a lock and key mechanism to these receptors, and that's octreotide. You might have heard of that, right? Mm-hmm. And what they do is somatostatin analogs is our fancy way of calling them, but what it does is it goes and attaches to it. And now what they've done is they've added a radiolabeled dye to it. Okay, so you add a radiolabeled dye to it. So now because of the octreotide, the lock goes into the key, and because of the radiolabeled dye, it lights it up. Okay, so you can see tumors, if they are neuroendocrine, light up on these scans. There's the octreotide scan was the older version of it. The gallium PET scan, as you talk about, the NET spot or whatever names we use them, is the newer version of it, okay? Now, what we can do is in after that, when that happens, and my son just bombarded the show to say hello to everybody.
That's so all right.
Hello to him.
What's up, buddy?
But what we can do is ultimately, all right, give me 1 second, guys.
Yeah, it's all good. No, this has happened to me plenty of times. This is the joy of working from home.
Exactly. Well, so what we can do is, in the functional imaging, we tend to all right, I'm gonna just give him back to his grandfather so no that worries. Actually, can you go back? Thank you. Thank you so much. He loves to bombard my shows every now.
Yeah, I know the feeling. I have a 3-year-old daughter who has made an appearance on the show several times. I embrace it. I show her to the NET community.
Yeah, that's true. But yeah, so coming back to the functional imaging, so the gallium PET scans, because these scans are much more specific to neuroendocrine tumor, they light up. If it lights up on that scan, 95% chance this is a neuroendocrine tumor. So it's telling you the function of the tumor, not just the size of it. It's not very good for sizes. It actually tells not a very good deal about like what the size of the tumors are, because when the light bulb goes, you cannot appropriately measure the size on that. But in general, what we can do is, in these scans, what it can find is some hidden areas of cancer, right? So if there's a small spot that is not changing the CT appearance as much, or it's like in the intestines, it's like rolled upon each other, and the tumors in the intestines are not visible on CAT scans and MRIs. So the gallium PET scans, or these special functional imaging scans, tend to light those up. Okay, and then you can actually see the tumor. So, coming back to the question our friend asked, if I have a high suspicion that my patient has a neuroendocrine tumor, like clinically or biochemically or some way, shape, or form, and the CAT scan's negative, I want to try to do that PET scan, because we have, CAT scan sensitivity, specificity is in the order of 60s to 80%. Different studies call different, but the PET scan's sensitivity and specificity, so its ability to diagnose this, is up to 95%, right? So we have a better test that's available. So we try to get it done. It's hard to get it done through insurances, and we have to sometimes appeal. We have to sometimes appeal, and I do that all the time. Like if my clinical concern is high, somebody on the other side is going to approve it. But that is the function that these scans fulfill. One is anatomic, look at picture, amount of disease. The other one looking at the extent, trying to look for hidden areas of cancer, stuff that we cannot see otherwise. And also it helps you see if somebody has a tumor, if that patient is a candidate for the special new kind of treatments called the peptide receptor radionuclide therapy, or PRRT.
Right. Folks, if you're joining us now or joining us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And we are here with Dr. Vijayvergia, who, if you have been watching the show so far, is very, very thorough. That last answer was perfect and laid the groundwork that I was hoping to lay. Rebecca, we appreciate your question. We're going to keep moving forward because we've got a lot of great questions coming in. So, Dr. Vijay, I have a lung carcinoid question, but it's about carcinoid syndrome. I'm going to ask it and see if you can field it. I know you're a GI medical oncologist. Lori says, would a lung net cause sweating, diarrhea, and vomiting possible carcinoid syndrome? So the question is carcinoid syndrome possible in a lung net patient?
Sure, absolutely. Carcinoid syndrome is definitely possible in lung carcinoids too. It is lung carcinoids. Flushing is a much more common symptom that we see than diarrhea in it. In general, that's what I've seen. But having said that, no patient reads the book. If you're concerned, if you talk about it, definitely discuss with your doctor, because I have to tell you, I have seen a pancreatic net patients who never develop carcinoid syndrome. They're functional nets. I have a patient, I can tell you, who had these symptoms, and if you have it, we cannot ignore them.
Yeah, no, that's a good point. Folks, another thing I've seen you doing is when you get a good answer, I've seen a couple of you sending you can go down the bottom of the Facebook Live, and there's like a love emoji, all these emojis that
there's also hate
emoji. No, we wouldn't do that. But it seems that you're sending those when you're getting some value. I really love that because it's a visual cue that we're doing our job. Now, there were a lot that came in when your son showed up, so people love that family life as well. But yeah, I see them coming in now. So yeah, that just helps me. If you get a great answer to a question, it really helped you. That's a visual cue that I can see very easily. It's like, hey, we're doing a good job. And we all like pats on the back, right? Let's keep asking questions. Question from Skip, who is a top fan of the foundation. Just yesterday, I had a lanreotide injection and had insomnia last night for the second time now. This was my 9th injection. I took Ambien and Xanax, and neither helped. Any suggestions? And several other people are interested in this question too.
Yep, I actually have patients who have that too. I definitely have patients who develop insomnia from the shot. It's underreported. It's under. Wow. I don't talk about it with patients initially as much, because it's not it's not a side effect that, oh my God, like it's life-threatening, we think, but definitely is reported. It's definitely shown. I have patients who've taken different, as you said, Ambien and Remeron. There's temazepam or Restoril. These are basically drugs that have helped patients. For the most part, it's in the first like few days after your treatment, and then it settles down. So, all these medicines are habit forming, so we try to avoid them. There is no magic pill, like literally none. Cutting down caffeine during that time has helped my patients immensely. Like during that time, like, in the initial, if you develop these symptoms, cutting caffeine out of your diet completely is very effective.
Got it. Got it. Well, I hope that helps, Skip. And it seems like Stephanie.
But it
Stephanie
is, I do hear you, Skip. It is definitely, I don't think you're imagining it. It's definitely related to your shots.
Coincidentally, the very next question is from Stephanie, which is also about sleep patterns with lanreotide treatment. But she says that she has the worst symptoms at night when she's trying to sleep: diarrhea, hypertension, heart palpitation, sugar levels. Is that impacted by it as well, or tied
It's
to
not
the?
known to be dire. So typically, some hormones are such that they get secreted more during a certain time of the day.
Mhm.
That's not known for serotonin, by itself, which is a hormone, or other biogenic, hormones that are secreted, which lead to carcinoid syndrome. Having said that, night is the time when all the other external stimuli around you go away, right? So night, it's the time when you are sort of more in tune with your body than you are when your son is like jumping on your head kind of a way. But so I think that's when you might be having some degree of them all through the day, but you realize it's more bothersome at nighttime. Also, the moving your dinner time a little bit earlier can help you with some of those diarrhea symptoms at night, to help you so that you can actually get some reasonable amount of sleep.
Yeah, that's a good point. From Karen, is there a problem if we build up our immune system? If we build up our immune system with this cancer? I went into a health food store to buy a product of mushrooms, and I was told that some patients with cancer should not build up their immune system. And a few other people have this question. I don't quite follow. Does this make sense?
If I'm understanding the question correctly, you're asking that, do these health products or these like health foods that are supposed to boost your immunity be deleterious in terms of your cancer? Is that, I think that's what you're asking me.
Yeah, that's
You
what
know, you would expect like immune stimulation to help everything,
right.
but is it deleterious or bad in this condition?
Yeah, she was
I,
told that some patients with cancer should not try to do that with these
I
food
in
products.
general, I feel that a lot of it is unproven in both ways. The people who are telling you that it helps are also making assumptions. The people who are telling you it doesn't help are probably also making assumptions based on some, anecdotal evidence. There is no prospective data for either. Discuss with your doctor. Some mushrooms can affect like some of the medication metabolism that you're undergoing. Some mushrooms have a lot of additives to it, which can be toxic. Like, they want to pick out one mushroom, but they also pick out one mushroom that's next to it, which could cause which could have a toxin and cause problems. So always remember that when you're thinking about health foods in general, try to definitely run it by your doctor and make sure that you really need it before you try them. That's how I feel.
This prompts an interesting question to me, because in that patient specifically, we already established this. Each case is different and has its own unique path. Is there more value in anecdotal evidence in this disease? And where I'm coming from is, like, I'll give you an example. We had one of the episodes, we had a doctor, and the topic of carcinoid rage came up.
Oh yeah.
And the doctor's like, I don't know. There's not really, we haven't really studied that. There's not a lot of science behind it, whatever. And everybody in the community on the comment section was like, it's real, like so many people joined in. And I find that people sharing their experience together can be helpful too in this disease, because there's so many different paths.
Absolutely. Absolutely. I think that's a very important point. We learn from our patients. So as I said, the first patient who called me about insomnia, I was like, "You've never told me that. I don't think that's related. I think you're just stressed out." Like, but then it happened with the second patient once, and then you're calling me. So
a
it's like
pattern.
it's a you see a small pattern, and that is something that we learn from our patients, right? Every patient teaches you something, and you can apply it for a patient, not the next one, but at some time down the line. And that's what excites me about medicine, that I'm not doing, even though I'm treating the same patient, it's still not doing the same thing over and over again. I have to keep thinking. That's why it's same, even with like, these health products that I talk about, there are some that are helpful. I take turmeric every day. I take it in my milk. I just boil it in my milk, drink it every day because it boosts your immunity. It prevents from coughs and colds. I'm an Indian. Ayurveda is like ingrained in me, like those kind of, but
Right.
I do it, and I've discussed it with, the medicine I take with my doctor that it's okay. You want to make sure it doesn't harm me, and they confirmed it. And then I was like, well, we'll see if it hurts. If it doesn't harm me, I want to try it. I think that is absolutely fine to do. What I say is just be careful. Don't want to just fall into a trap of something, but always make sure you discuss with your doctor when you do that.
Yeah, absolutely. You know what? I love this line that you said. Every patient teaches you something. I think that's so valid, and it speaks a lot to you and your practice, but also a lot of net doctors in this community, because you think about the doctor-patient relationship and that it's the other way, right? You have something to learn from your doctor.
Oh,
Clearly we do, but I love that it's reciprocal in the way you view things, that like each patient teaches you something
half of
different.
our conference time is discussing patients, right?
Yeah.
Why do we discuss patients at conferences? Yes, we want to help the patients, but we want everyone to learn from what we are doing. So we learn from patients, like you. That's why medicine is such a hands-on business. Working. Why does my son doesn't yet understand what working from home means? Because I rarely work from home. He thinks when I'm home, I'm free.
Oh, I know. Sometimes our significant others think so as well. All right, next question from Tina. Now, this is a broad one and not controversial, but up for discussion. Tina's simple question is surgery best for carcinoid, or we'll say, neuroendocrine tumors? And I know that sequencing is something that is often debated and discussed. So this is a good chance for us to lay some groundwork, right? Like, we have a few options of how to approach this.
Right.
Your
So
opinion.
any patient, right? I think we all believe that early stage patients, except like small pancreatic neuroendocrine tumor, and some very small lung, which we can follow in older people, most early stage neuroendocrine tumor, when you find, we want to take them out. So surgery is typically followed for those patients. And I think what our friend here is talking about is mostly for patients who have advanced disease, where like the cancer is spread to some other places. There you have surgery as an option. You have peptide receptor radiotherapy. You have octreotide. You have oral pills, everolimus. If it's pancreatic neuroendocrine, you have chemotherapy and sunitinib, and a lot of new drugs that are coming down the pike, right? So you have, and liver-directed therapy. There are tons of things we can do. How to do them, what to do. I personally follow the rule that, surgery is considered if I can get up to 70 to 90%. That's up for debate. How easily can I do it? If we can get that much of the disease out, the risk of undergoing surgery is justified by the benefit you get from it. Okay. If you cannot take out all of it, I consider surgery in some cases. Even I would go down to the 70%. We always have a discussion. Our surgeons make that decision. But basically, at our multidisciplinary tumor board, we see what is the extent of disease, how much they can debulk, and what is the effect on the patient from that surgery, right? You want to make sure that in trying to treat the cancer, I'm not harming the patient as an overall, because I'm not just treating cancer, I'm treating a patient. Right. So it's very important to have these discussions with the surgeon, and we make a plan together of whether we can do surgery, because the whole idea is you want to reset the clock for the patient. I'm sure you guys have heard that term a lot before, but it's basically true, right? You want to make sure that we want to help patients reset the clock, but in doing so, we don't want to make them debilitated, that they have a hard time doing that or living that long enough. So surgery is definitely an option that is we consider for every patient. Every patient that comes down the road, we definitely discuss that option. I don't think we offer it to everybody because all these different things I talked to you about, but that is something that we like. The fact that every patient gets discussed as tumor board is that because we want to make sure that we're not missing that opportunity. Then the second question comes, all the other treatments I talked to you about, how to treat. It's common sense. You want to start with a treatment that's effective, but also not very toxic. So, that's why somatostatin analogs or octreotide and lanreotide or whatever you call them sort of become the first line of your treatment, right? Because they're not very toxic, and they have a very good response, and they have a very good trajectory, or they are effective in this disease very much. And then you decide which one to choose. There's a lot of studies that are ongoing, which are comparing the different modalities together. There's a sector study, there's a compete trial. There's a lot of different studies that are studying it right now. But the way I personally think of it is, I think, caring for carcinoid or caring for neuroendocrine tumors is more of a marathon and not a sprint. So I want to use, I think over the course of time, my patient will go through most, if not all of these treatments. Really doesn't matter in terms of which one I do first. I do the one which suits the patient's overall health. So if somebody cannot travel, I had one patient who was a sole caregiver of her young daughter, right? So that sole caregiver was like, there's no way, what will I do if I do PRRT right now? Who's going to take care of my kid when I'm like for the 2 or 3 days that I'm not supposed to be next to my like young baby? And she didn't want to, like she was scared, even though we told her that it's not that big a deal. But, I think there we decided we're going to, liver-directed treatment first versus not that she's not going to get that treatment down the line, but I'm just saying that we adjusted based on patient preferences, what side effects we are looking at, and effectiveness wise, yes, one treatment that's proven, always go with one that's approved first, then looking for something that may or may not, like investigational things that come down the line.
Even though I said at the beginning of this question that this topic is very debated right now, a lot of the experts that we talk to kind of land on this same sentiment that you've just shared, that look, we're probably going to do many, if not all, of these treatment options at some point, and so it's not really a huge difference in when it falls in that timeline. And also the second point that you made, which I think is so important, that it depends on the patient's goals and life and all of that. And just like each case of this disease is different, each patient is different, and their priorities and goals are different. And I love that about neuroendocrine tumor doctors, is that everyone I've ever talked to considers that, like seriously considers that at the top of the list. And I just think I just love that, because I think it's such a big part of it. Now, you had mentioned PRRT, for example. Kathleen has a great question about PRRT. It says, do you have any stats on how long a series of 4 PRRT treatments will produce a stable outcome before tumors begin to grow again or tend to begin to grow again?
So we have data, right? So depends on what disease you are looking at. So the NETTER-1 study, there was a clinical trial where patients who had gut or small intestinal neuroendocrine tumors, half of them got PRRT, other half just got like a higher dose of octreotide in that. And when they were followed, patients who got the 4 doses of PRRT versus not, there was a 80% reduction in the chance of the cancer growing, but the average, the progression-free survival landed between 24 to 30 months for patients, like big difference, like somewhere in between that range. And their long-term survival landed between 40 and 50 months for the patients. So so that is the data that we have available from studies. How it applies to you, is this small intestinal neuroendocrine? Are you getting it for pancreatic neuroendocrine? And these are those subtleties that you can discuss with the doctor. But in general, we feel that if somebody has had more than a year after completion of their treatment, like the cancer has been stable and not growing, we call that a success in our minds. That I think that treatment has helped you.
Got it. Thank you. Next question from Sharon. Sharon said, also dealing with PRRT, Sharon says, I would like to know when organs are compromised, keeping you from getting PRRT. What new treatments are on the horizon? My kidneys are failing, and I get hydration twice weekly to keep them working at 30%. Previous to that, it was at 9%. Any thoughts?
So good question. Not sure I have the best answer to that right now. There are, I completely hear you. I have patients who have, unfortunately, kidney dysfunction, and the dose, is it deciding whether we give this treatment? And it's basically the PRRT is sort of filtered by the kidneys. And if the kidneys are not working great, what it can do is it can linger on longer and cause more damage to your bone marrow and cause more side effects than we want it to. That's, previously we used to think that even like anything below a normal kidney function, we couldn't give this treatment. As we've become more comfortable with the treatment, we are treating more and more patients. And if there's something called a GFR, or a glomerular filtration rate, that is just a fancy term for a test that we do to see how the kidneys are functioning. And if that is like greater than 30 or 40, we we have started like pushing the bar to treat patients even with, because it's like treatment versus, cancer progressing versus your kidneys worsening and going on the risk of death. You have to weigh that risk versus the benefit, right? So we as oncologists are getting slightly more comfortable treating patients with slightly poor kidney function than patients who have normal kidney, because when it just got started, everyone was like, we're only doing it for normal kidney function. And then we are getting better at that. Some of the newer compounds that are coming in, so far there is not any which is not cleared by the kidneys. Until you find something that is not cleared by the kidney, it's hard to say that it is without any risks, right? So we just have to identify the amount of risk, and as time moves on, what is the risk that the doctor is going to talk to you about, what are the risks associated with it. But in general, if the kidney function is a little less that magic number, we try to avoid it because the benefit is not worth the risks that it gives you.
Got it. Folks, we are just about halfway done, or a little over halfway done, with today's episode of Luncheon with the Experts, a Carcinoid Cancer Foundation program featuring Dr. Vijayvergia. And one little note, I see some comments that seem to be referring to a previous comment or question. Just so you all know, I don't necessarily see them in the same order that you send them, and I may not see the initial question. So each time you comment, if it's a question for me and not just a comment to someone else, just try to treat each comment or question rather as an individual isolated question, so that all the context is wrapped up in there for me, because I may not know what you're referring to if you say like also ... if I didn't see the initial part of that, then I can't help you. Next question, which kind of about anecdotal evidence in a way. Rebecca says, what are your thoughts on probiotics for midgut nets? We take so many different medications to prevent or control symptoms. I don't want to add more medicine if not needed or beneficial.
I think, you can just eat yogurt instead of getting probiotics. So, instead of trying to avoid medications, if you introduce, live cultured yogurt into your diet twice a day, that fulfills the need for a probiotic in general. Okay. Sorry, go ahead.
No, I was just gonna say, like, if you were lactose intolerant or something like that, would you also suggest like kimchi, sauerkraut, those sorts of?
Absolutely. Any of these things, anything that has live cultures, fermented stuff is really good and replenishes the gut flora. If you cannot do any of those for various reasons, as Rain was just talking about, what probiotics, do help to improve your digestive health in general. But if you don't, it's not that you're harming your body if you're not taking them. Try to prioritize your regular medicines. I know I had to take like an antibiotic 3 times a day. I swear it was so hard. I had to put alarm in my phone to know how to do it. So I get it. It's very hard to take so many medicines. Don't want you to be like prioritizing probiotic over something that's important for your health, right? So you can use all these separate food items to help it. There is no suggestion that, there's no data or prospective data that says that taking a probiotic improves your diet significant or improves your carcinoid symptoms significantly. But I think as I said, every person is different and is different. If it helps you, there's no harm in taking so if you take probiotic and your symptoms are better, you may be more inclined or more pushed to take it. But if you don't take it, it's not that you're harming your body or making it worse, because there's no data that supports or refutes this ideology.
Got it. Thank you for that. And a few other people had that question too. We also had a thank you for explaining all the differences between scans. And then another question about scans, which is like from Lisa, says, which scan is best if you have an unknown primary but a liver full of tumors? And now the doctor thinks it's in her ileum.
Mm-hmm. So I think for any of my patients who are neuroendocrine tumor with liver metastases and unknown primary, so the same case as you're talking about, that we don't know where the primary is, but we have tumors in the liver, I like to do one gallium PET scan at the time of diagnosis, because that can help me uncover where the primary is. Because remember, we just talked about the ileum is where it could be wrapped around and we can see it. Having said that, we have found that most patients where we cannot identify a primary, most of them have their primary in their small intestine. Think about it. Small intestine is so long and it just is, squished into a small area of space. It's wrapped around each other. Even with a PET scan, you may or may not see where the primary is. It's not 100% sure that you will see it. That's why if you don't see it, and it's not in the pancreas because it will light up on that PET scan. It's definitely not in the colon because that would light up and the colonoscopy would have shown it. It's not in the esophagus or the stomach or any of these areas because it would have shown it. So it's not in the lungs because the scans would have shown it. So if you don't see it anywhere, the only place we know these tumors can hide is in the small intestine. So that's why I think why your doctor is suggesting that if you cannot find it anywhere, it's probably coming from the small intestine. And that's how we treat all of those patients.
Got it. All right. Thanks for your question, Lisa. Hope that helped. Next question from Karen. If we take synthetic injections to lower our serotonin, I was reading about 2 amino acids that bring it down naturally. I was reading about this on PubMed. Do you have any thoughts on that and on ways to bring down serotonin?
I have not come across that information personally. So I would have to defer that question. I'm sorry, because I don't know much about that thing. I have to say there is a amino acid mixture that sometimes is being studied that repairs the lining of the intestine, that is being tried and tested for carcinoid syndrome diarrhea. There's one which is because it helps repair the lining. That's the only amino acid mixture that and we also know we give it IV for PRRT. But for the most part, I do not think there is known stuff which actually lowers your serotonin. I'm not aware of it.
Okay. Hey, Karen, good to see you. Not to give you extra work, but if you have that handy or know the link to that, feel free to add that into the comments, and then we can send that along. Moving along, next question from Bernadette. Also a question about symptoms. Is there treatment for flushing? Is there something that can be done for flushing?
So this, the 80% of patients with carcinoid syndrome have flushing. So it's one of the most common symptom and one of the most difficult to treat. Yes, we use the octreotide, lanreotide kinds of somatostatin analogs because they lower the hormones and that can improve flushing to a great degree, a lot of patients. Then if we can do surgery to, debulk, if the flushing is very bothersome and not going away with our treatments, we tend to consider debulking for functional tumors is how we call it, which means tumors are functional if they're producing the hormones and you're symptomatic from it. And if you can cut some of it out, that decreases the burden of the hormone because there's less tumor in the body. That has helped. I have done that in extreme cases. There is this new medicine called Zermello or tilotristat ethyl, which is used for diarrhea of carcinoid syndrome. But I have anecdotally, so there's I have anecdotally seen that it does help flushing to a certain degree as well, but it's hard to get it approved because that's not how the drug was studied in the first place.
Got it. Well, thanks for your question. Next question from Keith and many other people. Dr. Vijayvergia, have you prescribed Captem for any of your NET patients with metastatic or metastases to the liver? And if so, what kind of results have you seen? And I would just ask if you can do a quick, explanation of what Captem is.
Absolutely. So Captem is a chemotherapy combination. There are 2 oral chemo drugs. One is called capecitabine. So cap comes from the capecitabine, and temozolomide is the second one, and the tem comes from the temozolomide. So we call them Captem together. So what this chemotherapy has been tested in patients with pancreatic neuroendocrine tumors that has spread to the liver or anywhere else, right? So metastatic pancreatic neuroendocrine tumor that is spread to other places, this chemotherapy combination has been tested prospectively, which means we've given it to patients and then seen how they've done. And in general, it's a very effective therapy. The response rates are about 32%, which means more than 1/3 of the patients experience a significant shrinkage in their tumor. So most of the treatments we do for neuroendocrine tumors don't really cause shrinkage, just prevent growth. Here, this treatment actually causes shrinkage in up to 1/3 of the cases. And it also prolongs the time that you're on treatment, 22 months, up to 1 to 2 years for that matter. So it's a very effective treatment for those patients, and we use it very often. Again, it's chemotherapy, it has the side effects with it, so it's not the first thing I use, but I use it if I need an urgent response. So in somebody who has a pancreatic neuroendocrine tumor and liver metastases, and they're, pain or other symptoms, some symptoms that are happening for which I think the patient will benefit from a quick treatment response, that's when I consider Captem, or I consider them second, third line things like that for pancreatic neuroendocrine tumors. For other neuroendocrine tumors, just for like small intestine or other places, typically CAPTEM is not effective in those cancers, even if it's spread to the liver, unless you are a higher grade. So remember, there's something called the Ki-67 score that we do. It's basically checking for how many cells are actively dividing in the cancer at any given time. So it's just, it's like a visual, it's like a special stain we do. And that number can range from a 0 to 100%. So if most patients, neuroendocrine tumors, the grades are 0 to 3, 3 to 5, 3 to 10, something like that. Once you start getting into the range of 15, 20s, if it's over 20, you become a grade 3 neuroendocrine tumor. So those are the patients where we have used CAPTEM even for tumors that are not arising in the pancreas, so not starting, but otherwise for lower grade, it's specifically used for pancreatic neuroendocrine tumors.
Got it. Thanks, Keith. I appreciate your question. I hope that helped. Melanie says, how do they know where the primary tumor is?
Well, so what we do is we just scan and see where the tumors are. So the question that I think you're in your head is, did it start in the liver and went to the pancreas, or did it start in the pancreas and went to the liver, like chicken or the egg? Typically, tumors going into like pancreas or the intestines is not common, right? Liver is the most common site of metastasis for this disease. We know from the pattern of spread that we've studied over the years. And also, primaries are usually single lesions. Metastases are usually more than one lesion. So if you're seeing one spot in the pancreas and 10 in the liver, pancreas is the primary and liver is the metastatic site. Okay, so those are the things that help us differentiate.
Got it. Thanks for your question. Next question from David. What are your thoughts on having second biopsies years after diagnosis to determine if the grade has changed?
So I do that very often, but if there's clinical indication. I'm not going to do it if my patient's been completely stable for I have a patient who's 19 years on somatostatin analog and they have been doing fine and nothing's changing on scans. I'm not going to just subject them to the biopsy if I'm not going to do anything with the results, right? They're clinically doing okay. Sometimes what happens is you're scanning patients and their cancer grows more than you would expect a low-grade tumor to grow, right? Low-grade tumors in 3 to 6 months grow by 5 millimeters, 4 millimeters, a centimeter at the max. But if it's growing more than 3 or 4 centimeters in the small time frame, something doesn't jive, it's not making sense, then we'd like to biopsy one of the lesions to make sure that they've not transformed into a higher grade, because that changes how we're going to treat them. Do we use chemo? As I just told you, CAPTEM, like any of the chemos, they come use when that happens. So we do it then.
Got it. Moving along, folks, we got just a little bit more than 10 minutes. Great questions today. Great answers as well. Let's go with Jim. There's a lot of people that has this question. Is there a typical period after which a follow-up gallium scan is recommended? I have regular MRIs on my liver, but I wonder if there's a standard protocol for gallium follow-up to identify any potential development elsewhere.
So I typically do not do that. The reason that, I've only done that if I have a new symptom or the patient's clinical picture is not corresponding to what I'm seeing on the scans, right? So if I do the scan and the liver tumors are stable on the MRI, but the patient's losing weight or the carcinoid syndrome is getting worse or they're, more tired, it's just like clinically they're not behaving as if they are stable, then I like to do a PET scan repeated to see if there's disease other places, right? If you do scans, you will find tiny spots at other places, but if they're not clinically affecting how I'm going to treat the patient right now, I tend not to change my management because of it, right? So if I'm going to do a scan, it better change my management. As I just told you, the gallium PET scans, they give a good, like a bird's eye view picture, but they're not very good at measuring sizes per se. So as a result, you need these MRIs and scans to compare sizes over time. And the PET scans, it's much more radiation doses and much more, all these other things that come with it, that you want to avoid them if you don't need them. In general, typically, interestingly, European societies do say that every 2 to 3 years you could do a gallium PET if you're following somebody stably on a CAT scan, or an MRI. But here in US, we typically tend to follow the idea of not doing another, like an extra level of scan or a PET imaging, unless there's a clinical indication to do that.
Got it. All right. I hope that helps. Thanks for your question, Jim. Next question from Ruth. What would be the next line of treatment after PRRT if the patient begins to have problems again? I know we've talked about PRRT a bit today.
So we talked about all the different treatment options, right? There, don't know which one you've had before, which one is available. So you have oral treatments available, you pills, there, targeted therapies, there's chemotherapy. You also have other treatment options that are there, like what do you call it? The liver-directed treatments that are available. The question about PRRT retreatment comes up, like, can you use PRRT again if someone had a great response to PRRT first place? There is some data from Europe. It's not something that we've done, but there's a prospective study that is being developed, hopefully, that we should do. It's like area of unmet need is what you're talking about. Can you use PRRT safely again, and how effective it's going to be? We just don't know that answer yet.
Got it. Thanks, Ruth. Hope that helped. Let's see. Okay, next question from Barbara. Question: my tumor was in the ileum, I had a bowel resection, no further treatment, and I've been NED, no evidence of disease since. However, only followed with CTs, never had gallium. How do I know that was a primary and I have no other tumors without further tests being done?
So in this day and age, when a patient is diagnosed with an early stage neuroendocrine tumor going for surgery, I do like to do one gallium PET scan to make sure that we are just dealing with localized disease. So at one PET scan around the time of diagnosis, or if they've already had surgery, which happens many times, they come to me after surgery, one gallium PET scan to establish there's no evidence of disease anywhere else is something that is reasonable, and I do it. After that, I tend to, and most guidelines just suggest doing CAT scan or MRI follow-ups, because the areas of disease that are in the liver and the abdomen are very well picked up by CAT scans and MRIs. And doing PET scan, you'd sometimes pick up a lot of noise. You don't, that it may not be tumor, it may be something else, and then you're chasing things after it, and there is no data to date that has shown that it actually makes a difference. On a separate note, if a patient of mine who had a surgery for a neuroendocrine tumor comes in with bone pain or some areas, some symptoms that don't get explained, so if it's clinically indicated, we do repeat PET scans too.
Got it. I had another question from Lisa, and this goes back to our discussion about Zermello and serotonin. So Lisa says, is there anything else besides Zermello for lowering serotonin? Because my doctor says if you can find a way to lower it, let me know, but he doesn't use Zermello. So if that's not an option for Lisa, any other advice there?
So unfortunately, there's no medications that are approved or available that can lower serotonin by itself. There's somatostatin analogs, so octreotide, lanreotide, and there is this medicine called telotrestat ethyl or Zermello. Whether Zermello is helpful, like just by reducing serotonin, does it actually help the cancer? We do not know the answer to that question. We do know that it decreases diarrhea. Right? Does it help other issues that are associated with carcinoid? We do not have any indication of that. So even if I have patients who have elevated serotonin alone, I do not recommend them to take this medicine. If you have diarrhea that's not controlled, I absolutely recommend this medicine, but not just for an elevated serotonin, because we really do not know if it actually helps or not.
Mm-hmm. Got it. Interesting question from Joan. Are vibration plates? It's an exercise machine. Are you familiar with these?
I've heard about them.
Yeah, it's like a whole body vibration machine. Okay. Are they? So you may not know the answer to this question. Are they helpful or harmful for neuroendocrine tumors, or is there any reason you would think that they would be?
I have not come across any data that says they're harmful or helpful. Exercising in general is good for all cancers, no matter what kind of exercising. So I would, if my patient told me, I would definitely say, why not? The only time I could think of is, if you have a big hernia or something, or you just had a surgery, you don't want to go onto these machines at that time. Mm-hmm. But other than that, I don't see a reason why you couldn't.
Got it. Okay. Well, hopefully that helps. I've been on one of those before. It is
What is it
interesting.
called? What is it called?
A vibration plate. It's literally like a,
Okay.
plate. You can picture like a treadmill or something like that.
Uh-huh.
Without it moving, it moves like that.
Like
It's
every part of the body, just like
yeah.
exercise.
Your whole body is vibrating. People use it for weight loss and things
Interesting.
like that. But yeah,
But yeah, as I said, I think exercise of any kind is good.
yeah. I mean, I imagine it gets gets your heart rate up, and that's kind
Yeah,
of the goal
it
with
decreases
exercise.
inflammation in the body, gets your heart like this thing, all exercise is good in general. It would just get my heart rate up because I'd be scared I'll fall from it, but
Yeah,
that's
well, I think that's the point. And your core's having to stabilize so that you're not just getting thrown around too. So yeah, we don't have much more information on that, but
I learned something today.
yeah, you learn something from your patients, don't you? I feel like I've heard that somewhere today. Wendy, who is a top fan of the foundation. Hey, Wendy, good to see you. Says, I have a PNET already whippled and liver resections, now diagnosed with a second liver neuroendocrine carcinoma. Can you have more than one liver resection? Is the question.
Yes, you can.
Okay.
But again, it's a very nuanced question. How much did they take out before? Where is the location of the new spot? What is your liver function like? Is there other spots associated with it? How close you are to the surgery that you just had? There are so many questions that go into it. I've had, so that's why it's hard to, but just the fact that you've had a prior liver resection doesn't mean you cannot have a second liver resection. There are too many nuances that you need to review.
Yeah.
But again, just that alone factor doesn't preclude it.
Got it. Thanks, Wendy. Hopefully that helps a little bit. First of all, or not first of all, but a side note, Dr. Aman Chauhan says, hello from Kentucky, Dr. Vijayvergia and Rain. Hello, Dr. Chauhan. Good to see you.
Hello, Aman.
Yeah. He tends to hang out and watch the show and critique us.
He's an
He's been on the
amazing
show before. I think we're
professional.
going to have him back someday soon. Hopefully, good to see your name at least, sir. So I have a question. We talked earlier about the previous 5 to 10 years, specifically the previous 5 years, and what they've kind of brought to this community in terms of treatment options, ability to diagnose, etc. Let's flip that coin over and look at the next 5 years.
Mhm.
What do you suspect? What do you expect? What are you hopeful for? What would you like to see happen? What would help you do your job better in the next 5 years?
So, obviously, if I could cure the disease, that would be amazing. But always, you hope for the stars and you get to the moon kind of a way, right? So we will hope for that. But in general, I think the power of, trying to harness the power of PRRT a little bit more. Dr. Chauhan here is doing a great job at that too. That is that is definitely something we want to do better at. Is it combinations with other treatments, how to best utilize it? These are different things that we don't know about. Sequencing, right? What is the best sequence? Can I tell my patients you should do this before the other one? Those are all studies that are ongoing. Using some of the newer, there's a ton of newer drugs that are actually in the pipeline, which hopefully some will get FDA approved in the next year or after. We will have to just do a better job at educating all providers to use those medicines for our patients. And then finally, I think what's very important is improving access. I really feel a very important thing that I want to personally invest in over the next many years is I don't want my patients to travel for a PET scan. I don't want my patients to try. It's very important parts of their lives are being spent in just getting to their right doctor, getting to their and there was this very nice article that was published in the Lancet journal. It's a very coveted one of our journals that we have, and where they presented like a world map of how many PET scanners are available in North America. Still way pretty good if I'm just looking at the entire world, because I know your show does reach out to patients across the globe.
Yeah.
The if you don't have a PET scan, you cannot go to the next level of actually making a difference in patients' lives, right?
Yep.
So access to care and ability to get our using machine learning, using telemedicine, using all these different amazing AI technologies, machine learning algorithms. Can you treat patients? Me being here and my patients in India, can I treat them? I don't know. These are just ideas that are in there, but I think that is we are doing our best, everybody, all the doctors, to develop new treatments, but we also have to make sure we can get them to all our patients.
Absolutely, absolutely. I have one final comment from Rebecca. It says, thanks so much for your time, Dr. V and Rain. You guys are the best, and stay strong, fellow zebras. I think that is a great sentiment to end on today. That is our show. Dr. Vijayvergia, thank you so much for spending some time with us today.
Thank you so much. Such a pleasure, and I appreciate all the comments. And I apologize for the little
Oh,
inconvenience
listen.
of my son barging in.
No, we're going to send him some love too. And I have to tell you, I didn't mention these comments, but as I got to that part of the show and seeing the comments, everybody was talking about how cute and adorable he was. So please thank him too for sharing Mommy with us for an hour, and send him our love as well. And also thanks to you all at home. As always, we hope this program helped answer some of your questions. And as always, if you didn't get all your questions answered, I always urge you to reach out to CCF here on the Facebook page or at carcinoid.org. They will get you that information, I promise you. Thanks again to our presenting sponsor, Tercera Therapeutics. We could not do this program without them. And finally, my name is Rain Bennett. Thank you for watching. I have been your host. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody.